Let's get started with our first presenters, Dr. Mike Smith, Obstetrician-Gynecologist, and Dr. Lona Vyas, Consultant Urologist Surgeon, both from Integra Healthcare. They will be presenting on pelvic cancer survivorship best practice. Dr. Mike Smith is a highly trained and experienced obstetrician and gynecologist who joined Integra Healthcare in the Cayman Islands in June 2023. Dr. Lona Vyas is a consultant urological surgeon with over 18 years of experience. Doctors, I hand you the podium, and it's all yours.
Thank you.
Thank you. First, we'd like to thank everybody for coming and getting up on a Saturday morning. We do appreciate it. And thank you to the organisers for inviting us to speak. I've got no conflict of interest, and any clinical slides, I've got the written patient consent for showing them. There's no identifiable features on those slides.
And that's the same for me. So in 2022, there's 20 million new cases of cancer worldwide, about 9.7 million cancer deaths. 1 in 5 people will develop cancer in their lifetime. 1 in 9 men die from cancer, and 1 in 12 women also die from cancer. But there's hope. 53.5 million people are surviving cancer within 5 years of diagnosis.
With respect to gynecological cancer, even just in the US, it means there are greater than 1 million survivors of gynecological cancers. These make up approximately 10% of all cancer survivors, and it's predicted that these will go up by 33% over the next decade.
From a male cancer point of view, age-standardized 1, 5, and 10-year survival, the most common cancers are shown here, with prostate cancer being one of them, bowel and lung.
A person is considered cancer survivor from the time of diagnosis through the balance of their life. There are many types of survivors, including those living with cancer and those free of cancer, and what being a survivor means to the individual may change over time. And some people may prefer an entirely different term to describe themselves than cancer survivor.
So definitions for survivorship vary quite a lot in the literature, and this can range between 5, 8, or 10 years after completion of first-line treatment. And over 50% of survivors still see themselves as cancer patients later on.
In 2005, an Institute of Medicine report divided the components of survivorship into 4 categories. These include prevention of new and recurrent cancer, surveillance for cancer spread or recurrence, evaluation of cancer and treatment side effects, and coordination of follow-up.
So in terms of quality of life, the WHO defines this as an individual's perception of their position in life, and this is usually based on culture, their value systems, but also in the context of their goals, expectations, and concerns. So, we are really sorry to say, I'm afraid I have bad news. As you know, we were really worried. You have cancer. People have heard this, maybe even firsthand in this room, and certainly, I'm sure, in clinical practice. This used to be a bit of a death sentence, and people were worried. But now the tide has changed, and there's new hope. And as we saw earlier, there's a lot more survival at 10 years now, with more than 50% in most of the cancers. So we have to start thinking about quality of life and living again. So this is a bit of a busy slide, but in terms of male urological cancers, in the stage 1, for prostate, penile, and testicular cancer, it's over 90% survival at 10 years. But even in the stage 4s of these cancers, they have reasonably good survival at 2/3 of patients are surviving. In penile cancer, it's slightly different because men are less motivated to get treatment, and have debilitating symptoms like lymphedema. And so because of that reduced motivation, the outcomes are not as good. This is slightly different in terms of bladder and kidney cancer. For stage 1 in both diseases, there's an 80 to 90% survival within 5 years. But in the stage 4, it can be down to sort of 10%. And this is why it's really important that we are thinking about complications, about not only cancer control, but organ-sparing surgery. It's really important that we have a multidisciplinary approach and joint decision-making for an individualized approach for these patients. What we use is pre-op education, seminars, information leaflets for these patients to achieve a better quality of life post-treatment. So within urological cancers, prostate cancer is the leading cancer for survivorship and research. This is mainly because it's the most prevalent. And the survivorship programs are very translatable to other pelvic oncological surgery and outcomes. So there's a concept which was brought in by the Americans of pentafactor, and I think that's growing. And it's really thinking about maximizing cancer control while preserving sexual function, continence, and now fertility. It's not just about survival anymore and quality of life, it's thinking about the next generation, but still considering biochemical recurrence, surgical complications, and having your margins free. The picture on the left of the slide is just a reminder about metabolic syndrome, and to take this into consideration when we're thinking about survivorship, because metabolic syndrome is a huge topic, and it's mainly around cardiovascular disease and ED, and so this can be a contributing factor to survivors. So I'd like to elaborate a bit further on sexual function and incontinence. The outcomes are dependent on surgical technique. So in prostatectomies, we consider bilateral nerve-sparing radical prostatectomy or unilateral disease, because these will have better outcomes in terms of potency. What this means is you're peeling off the nerves around the prostate, just on the fascial planes, on the outside, to try and preserve their potency. What was really interesting when you look at research is the data is very heterogeneous, and it describes ED post-operatively between 14 to 90%. And what's really interesting is that the journals that have fewer ED rates are urological journals, and higher ED rates are in the sexual medicine journals that are written by sex therapists. And there's certainly an element of, are we asking the right questions in our practice? Certainly when I started doing this in the late 2000s, men were being seen for 5 years and seeing their cancer surgeon, and would never say that they had ED, and then they would come and see me, and they would be saying that they've had it the whole time. They were just scared to tell their surgeon because they didn't want to let them down. So certainly we should be considering this very early on. In terms of what do men want, well, about a third of men would like bilateral nerve-sparing surgery to try and save their potency. But also, there are about a third of patients who want to have nerve sparing but can't. So around 2/3 of men are worried about ED within surgery. What I'd also like to touch upon is around rehab programs and what I call the concept of penile gym. So we know that PDE5 inhibitors certainly help men to achieve oxygenation of the penis and keep the blood flowing. As they say, if you don't use it, you lose it. So we are keen to have people on programs people like me who are interested in the field will start men on these rehab programs quite early on in their journey, but around 3 months post-operatively, about 3/4 of urologists will be taking this more seriously. In terms of other medical treatments, we have to think about what patients want, and it's a long conversation with them regarding what's going to suit them, and that's where the individualized approach occurs. Low intensity shockwave treatment is the new kid on the block, but it's very promising data that's coming through, and this is men requiring about 3 to 6 sessions of a scanner being put onto their penis, and that's improving blood flow. It's Saturday morning, and so I thought I'd save you some penis pictures, certainly after breakfast. So I have a few diagrams at the bottom, trying to be a bit more tasteful than, what you would for the shock value. In terms of devices, these are mechanical, and you can see that, these are the pumps. They're very mechanical. It's essentially a suction device that brings blood into the penis and gives people good rigidity. Some couples love it, other people find it terrible. And then definitive treatment in terms of survivorship and erections are penile implants. These are about 2 to 3% of men, and there are 2 types, malleable and inflatable, which you can see here just in the corner. These again take over the mechanical aspect, but they are definitive in terms of rigidity success. But I did about 40 implants in a year, and 4 patients didn't ever use them. So it's really interesting that some men just want it psychologically, so they know that they can perform, so to speak, but never need to. In terms of continence, the overall figures worldwide in terms of stress urinary incontinence is 20% after a year, and that's for men who will have leakage on coughing or laughing, and they're wearing pads quite regularly. For them, we will use pelvic floor exercises, and physios are really, really important with that. And again, in our seminars, we think about discussing pelvic floor exercises more carefully with them. But some men do need definitive treatment with male slings if their incontinence isn't too bad and they're only using sort of 3 or 4 pads a day. But if it's debilitating, then we use artificial sphincters to give them confidence in their continence. In terms of what we call de novo overactivity, because if the prostate is removed, and that this can be in any pelvic cancers, then the obstruction is relieved, and so the bladder can overwork and you can get leakage for those reasons. And for them, we give them medical treatment or Botox. And no, we don't give the spare Botox to their face.
When it comes to gynecological cancer, approximately 50% of cancer survivors still experience health concerns and long-term side effects in the future. This requires continued follow-up by the right team. The list includes, but is not restricted to, neurological symptoms, sleep disturbance, fatigue, sexual dysfunction, bowel and urinary problems, and lymphedema. Over the past 100 years or more, focus has been on treatment to help cure the cancer, not unreasonably. It's only fairly recently that emphasis has gone on looking after the symptoms of the patient afterwards. It was only in 2022 that Perenboom et al. Looked at what survivors of gynecological cancer actually want and what concerns them. The most frequent survivorship concerns were fear of cancer recurrence, weight loss, and long-term side effects and their management. The highest-ranked survivorship program components include assistance with nutrition, weight loss, and stress reduction. However, the relative importance of these factors change with age. For example, older patients, those greater than 64 years of age, were less likely to report concern with losing weight, They're less likely to report problems with sex life and strain in family relationships compared to younger patients. The importance of these factors also changes with staging of the disease. What's important for somebody with an early stage disease is very different than somebody with advanced cancer. For example, the patients with advanced ovarian cancer were less likely to desire assistance with weight loss. For them, it's about maintaining their nutrition. Compared with ovarian, fallopian tube, primary peritoneal cancer survivors, endometrial cancer survivors were less likely to desire nutritional education. So these patients were wanting to lose weight. Typically, these are patients with a high BMI. The key point is that variation in patient preferences and differences among clinical subgroups highlight the need for tailored survivorship care. With respect to individualizing a survivorship program for a patient, what is a priority for somebody in one country may be not the same as a patient in another country. This is the Christie Hospital. It's the largest standalone cancer center in Europe. This is where I was lead for gynecological cancer. Trying to put a survivorship program in for patients here was relatively easy, even though patients didn't want to travel long distances. And long distances for them were our catchment area was 3.2 million patients and stretched for about 80 miles at its outermost parts. And for them, traveling 80 miles when you're feeling unwell or want support was a problem. And so we set up outreach clinics where we could provide that. On Cayman, it's even worse. It's, traveling overseas for the correct care, and we would hope that we would bring a lot of that care closer to home now. At Christie Hospital, at the hospital, it was easy because we had 5 surgical gynecological oncologists, 4 medical oncologists that specialized in gynae cancer, 3 radiation oncologists. We had teams of cancer nurse specialists. We had physiotherapists, occupational therapists. We had a WIG department. So it was relatively easy. Here, it's all about coordinating the correct multidisciplinary care. We start by trying to reduce the symptoms after treatment by tailoring the correct surgery for the patient. And so we try and reduce the extent of surgery where appropriate without compromising the cure rate. And obviously, nobody wants to compromise that cure rate. It's not appropriate with all gynecological cancers, and so I'm going to start off by telling you the ones where it is. So something like an early stage vulval cancer, and this is an approximate 1 to 2 centimeter vulval tumor on the right side of the patient, and we need to tailor the treatment. So let me run you through historically what was done for this. About 100 years ago, up until the 1970s or 80s, a butterfly incision, as in diagram A, was used, where we'd take the nodes en bloc with the tumor as a massive big resection. Then in the 70s and 80s, Berwick and Hacker championed the idea of the triple incision technique, where we took out the lymph nodes out of 2 separate groin incisions and removed the initial tumor, either with a hemivulvectomy, removing half of the vulva, or a wide local excision, as in this diagram. And then more recently, over the last 10 years or so, we've introduced sentinel node technology, where we can remove the sentinel node, so the main node, rather than all of the lymph nodes in the groins. So looking at the morbidity of that, what difference does that make? Well, in an en bloc resection, there was a wound breakdown of between 70 and 90%. So you'd expect a wound breakdown in vast majority of cases. In the triple incision, that's reduced significantly. And so you'd get a wound breakdown in approximately 17 to 39%. A lymphocele, so a collection of lymph fluid causing a cyst in the groin, would expect in 7 to 40%, and lymphedema between 14 and 48%. Then with introduction of sentinel node technology, we've reduced lymphocele rates and lymphedema rates. Lymphedema is a massive problem for patients and is seen as a reminder of their cancer if they've got it. It's 5 times lower doing groin sentinel nodes than a full lymphadenectomy. So this is a sentinel node in the groin. We use it for tumors less than 4 centimeters. It needs to be more than 2 centimeters away from the midline, although you need, if it's not, you need to do bilateral nodes. And you need to have no suspicious nodes clinically or on the imaging. And then you can use various techniques, and this one is using a combination of radioactivity, technetium, so you use a little Geiger counter, and a blue dye. When it comes to endometrial cancer, the morbidity of lymphadenectomy is also a significant problem. We see lymphedema rates of 20 to 25% for a full pelvic lymphadenectomy, and a lymphocyst rate of between 10 and 25% of cases. 2/3 of these spontaneously regress without any intervention, but the incidence of these increases if they also get adjuvant radiotherapy. There's also a possibility of nerve injury to the genitofemoral or the obturator nerves whilst performing a full pelvic lymphadenectomy. And so for this reason, this lesion alone, we've moved to sentinel lymph nodes. Now, this is a patient that I inherited from one of my colleagues that underwent a full pelvic lymphadenectomy followed by radiotherapy. And so when he retired, I ended up having to look after this poor lady. Our lymphedema services were not very good around Manchester at the time. And so I discharged her after 10 years of follow-up, cancer-free, but still looking like this. We're having to use different size shoes. So anything we can do to reduce the chances of this is vital. This is I apologize to the people on the right side of the forum because you're not going to be able to see my laser pointer very well. But this is a video of myself doing a full pelvic lymph node dissection using robotic surgery. So using robotic surgery for a start is going to be better for the patient. We use 8mm ports, so little incisions to put our instruments in. And then I sit in this corner of the same room in a surgeon's console, and I put my fingers and thumbs through loops. And when I move those loops, my instruments move how I want them. So it's like doing keyhole surgery, but using open surgery techniques. So here you can see the right pelvic sidewall. There's an ovary there with a tube there, and this is the main blood supply into that ovary, and I'm opening up the spaces here. And one of the things that first you can notice is that there's wristed instrumentation, so I can actually, it's not like old-fashioned straight stick laparoscopy keyhole surgery. This is wristed instrumentation. I'm controlling the camera, I'm controlling both of these and my assistant instrument by clutching in and out with foot pedals. And you can see that one of the things that really hits you straight away is there's very little blood loss. There's reduced blood loss, there's reduced pain, which is crucial for the patient's recovery. So what I'm doing to start with is finding all the anatomy, isolating the lymph node packages, and then once I've done that, I'm going to remove the lymph nodes. And you can see the magnification's very good, so the chances of complications are much less than with open surgery. The main reason I'm showing you this is to show the extent of the dissection you need to do a full lymphadenectomy. Now, a full lymphadenectomy is still appropriate in some cases, but if we can avoid it and just do sentinel nodes, it's better. The idea of sentinel nodes is that the lymph nodes from any organ are drained in a stepwise chain fashion. So if you can manage to identify the first one in that chain and remove that, then you've got your answer. If that's cancer-free, all the subsequent ones are cancer-free, and if that one's got cancer, that's all you need to know, because then that will help direct whether this patient will benefit from any adjuvant chemotherapy or radiotherapy. So you can see these are the external iliac artery and vein that I'm stripping it off. And so if you make a hole in that, it's a bad day for everybody, because this is the artery is the blood supply to the leg. It becomes the femoral artery just under here. And this is the vein. And so this is all the blood from the leg coming through here. So you can see the accuracy that we can get with robotic surgery is much better. There's the pubic ramus. There's the back of the pubis there. And that's the lymph node. That's one of the lymph node packages from the external iliac. I have done the same for the internal iliac here and the obturator nodes in there. So the difference is This is a sentinel lymph node dissection. You can see there's a lower incidence of lymphedema, lymphocyst. There's an increased pickup of positive nodes because the pathologist can concentrate on one node rather than approximately 20 from either side. And there's a decreased operative time. I inject ICG, which is a dye into the cervix. It takes it up. It goes along the lymphatic channels. And when I press a pedal on my robot, then it shines an infrared light onto it, which you can see causes luminescence. And I can identify it and remove it. And you can see this is an unedited video, so you can see how quick it is compared to the edited video that you watched before, removing all of the lymph nodes. The main benefit is their reduction in lymphedema. It's almost down to 0 in this case. As you heard from Lona regarding nerve-sparing surgery for men, well, nerve-sparing surgery is also very important for women. And in the case of a radical hysterectomy, which we do for cervical cancer, the traditional open radical technique sacrifices all or part of the hypogastric nerve with its branches. Now, although with time, some of that function does come back, the hypogastric nerve is very crucial. It goes to the bladder, the bowel, and to the vagina. And so it can cause bladder dysfunction. These women can lose feeling about when they need to go to the toilet, and so may need intermittent self-catheterization or a permanent catheter for the rest of their life. They undergo constipation, which can be a real problem, and it can add to sexual dysfunction that we see after cancer surgery for gynecological patients, because in this case, it reduces lubrication. This is the nerve. This is a Japanese study that they did on cadavers as open surgery. And you can see it's a tiny thing. And so with traditional open surgery, it's very difficult to see. It's down here. But with robotic surgery, we can identify it much better. The magnification's much better. We can dissect it out and try and preserve as much of the nerve and its branches as possible. One of the major comorbidities is actually non-surgical, and this is one that really troubles patients, and it's usually when they use taxane chemotherapy, which is one of the main chemotherapies that our medical oncologists will use for gynecological cancers, particularly ovarian, but now more and more for endometrial cancers and cervical cancers. What it does is it causes a tingling or pain in the hands or a loss of sensation. And once these patients have got it, they've usually got it for life. And they will come into clinic, even though you've told them that they've had all of these interventions to try and reduce it, still complaining of it. It's still one of their main problems. So what can you do? Well, you can try and prevent it from happening in the first place. Other causes, predisposing causes for it, include diabetes, so you can try and optimize their diabetic care. The only clinically significant treatment for this is duloxetine. Other things have been tried. They haven't reached statistical significance yet in clinical trials, but are encouraging, such as acupuncture has been used, scrambler therapy, and so on. So it's crucial that the patient sees the right person so they can direct them in the right way to try and get the best care. Fertility. Fertility is a major problem for some of our patients, the younger patients, and that's particularly cervical cancer, which typically occurs in the 30s rather than vulval cancer, which typically occurs in the 60s, 70s, and later. So over the years, our decisions regarding childbirth and families have been delayed and delayed. And you can see this is a study from Sweden where they looked at the average age of childbirth and first childbirth. And we can see that since the 1960s, the average age of first childbirth has been increasing. So for endometrial cancer, we can still do things as long as it's an early stage, early grade. So early grade, early stage, we can give them progestins, and we can give them high-dose oral ones or better Mirena coil. We expect a complete pathological response in approximately 50% of the endometrial cancers over the first 6 to 12 months. We monitor with biopsies and MRI scans, and they can try and conceive following 2 negative biopsies. We combine it with weight loss surgery. So once again, it's that multidisciplinary approach. Because if we cure somebody from early stage endometrial cancer, they are more likely to die afterwards because of their weight-related issues than they are from the cancer. So normally we would recommend, if they've still got significant weight problems, weight loss surgery in the form of a laparoscopic sleeve gastrectomy or other interventions, because if they've still got that driver for the cancer, they're still at high risk of it coming back. And that's, we see a recurrence rate of 35%. And so basically, once they've had their child, if they have conceived and given birth, we would recommend a hysterectomy immediately following childbirth. Cervical cancer, now the standard of care for cervical cancer is fertility sparing unless the patient has definitely completed their family, and we've got a 98 to 99% cure rate, as is for stage 1A2 when we take out their lymph nodes. Stage 1B1 traditionally has been treated with a radical hysterectomy. However, there is a fertility-sparing option, which I do, and it's called a radical trachelectomy. It's a fairly complex operation, and what we do is remove the cervix, as we would with a radical hysterectomy, with all the tissue around it and the top of the vagina, and then refashion a cervix, put a stitch in so they can try and hold a pregnancy, and then reattach everything. So we can see here, and I once again apologize to the people on the right side of the room, it's this tissue here, and then I reattach here and here. So this is a quick video showing me reattaching the cervix, to the new cervix, to the top of the vagina using robotic surgery. Once again, the wristed articulation of the robot allows me to put these sutures in accurately and get a nice strength, because this has got to hold for the rest of the patient's life. Previously, trying to do this laparoscopically was very, very difficult because you just can't get the angles to put the sutures in. The outcomes from trachelectomy are usually very good. We would only offer this in the right cases. We can't compromise the oncological outcome. It's not, do you want a family or do you want a cure? It's, do you want both? Even if the patient doesn't know whether they want to conceive, it's about having the choice. A lot of these women had not thought about a family, or at least thought about a family in the very near future when their cancer diagnosis has been given to them. And so all of a sudden, it throws it into very big perspective for them to make these kind of decisions. Not all patients that have undergone a trachelectomy have tried to conceive afterwards, because, as I say, it's about having that choice, and it might not be the right thing in the future. But if you do the radical hysterectomy, there's no chance. So the outcomes, they are the same for standard surgery as fertility sparing. You'd only use robotic ones for less than 2 centimeters. 27% of these patients attempt to conceive, and 59% will manage to conceive. You can still use IVF techniques in these patients if needed, and we have used them. The first trimester miscarriage rate is not increased, but the second trimester miscarriage rate is. 86% of them will deliver after 32 weeks. And so that's really important, that these babies are going to do really well after 32 weeks.
So we've talked about sexual function and continence and fertility in women. Now it's about the boys. So with increased life expectancy in these men, it's really important that we're thinking about sperm banking prior to any kind of oncological treatment. And there's an increasing body of evidence that proves this. Certainly there is a pandemic in terms of fertility at the moment. The WHO say 1 in 6 people have infertility. The trends of fertility are decreasing quite rapidly with time. And so it's really important that we start thinking about this in the forefront of our mind. It's not about the survival of patients, it's also about the next generation. So this is a few studies to show about sperm quality, and the Scandinavians have looked at this quite carefully over many, many years. We can always trust in them. and they've been seeing these decline in sperm quality in that region. This is not even plateauing, so it's still coming down, and we don't know where it will plateau. And we don't quite know why this is the case, and I find it absolutely fascinating. You may also, or may not. And what we think theoretically is that things like estrogen-mimicking chemicals in plastics and other environmental factors are causing this problem in women with male fetuses in utero. So this is a huge thing in the world, and luckily I'm really interested in it. So should we be making it mandatory for all men with cancers, not just pelvic cancers, but all cancers, cryopreserving? And I think that certainly should be considered more and more, especially because sperm quality in men isn't great. So we also know, around fertility and survivorship, again, in urology, it's usually around testicular cancers because men have been cryopreserving for quite some time now. And we know that men with testicular cancer are less likely to have children. So how do they feel about it? Well, and these are a few things that men have said around their fertility, because fertility is, usually has been a problem around women, and men haven't talked about this, and it's sort of coming to the forefront because the landscape is changing and they feel emasculated, they feel depressed. So it's important that we, as clinicians or allied health professionals, talk to people, even friends, about their fertility. So what should we be doing? Well, I think even if you're thinking about cancer diagnostics, put fertility into that conversation. Maybe think about doing a semen analysis or sending them to a male fertility specialist, someone like me or others, really before you're even thinking about oncological therapies or surgery. And if they have got low sperm counts or poor quality sperm, you should be thinking about doing either an oncotese, which is used for testicular cancer patients, to try and preserve the sperm before the testis is removed. And this is an image just showing the testis there. Sorry, a bit later in the morning. Now it's testicular images, but hopefully they're not too offensive. This is basically dilated tubules. So within that, you have millions of sperm. And as you can see, that there's discolored tubules around circumferentially and slightly dilated tubules in the middle. And what we have is the embryologist is in the operating theatre with me, and essentially we're looking at sperm and sperm quality in real time. And we are able to do that on island as an emergency. So it's really important that we think about offering patients this. Once they have, it's not just the journey in terms of fertility is not over just because we've cryopreserved sperm. So what I would like to do is to see patients after they've had treatment and to repeat the semen analyses at that point, because if they've have got good quality sperm, then of course we don't need to cryopreserve their sperm anymore, which has a cost implication, but also they can feel confident that they will have. And confidence is so important in terms of stress and fertility that they can go on to conceive naturally. If they can't, then we can support them through their fertility journey after their cancer treatment. And if they need assisted conception techniques, then we can work alongside fertility clinics to help them with this. But it's not all doom and gloom. And this was a study which was around 73 patients of testicular cancer post-operatively, and around 13 patients went on to achieve natural conception. So it's nice that we can give men hope as well, and not just say you're going to have fertility problems. Not all men do, and that's why it's important that they're supported through that survivorship journey. So in summary, I think all male oncological patients should be considering cryopreservation, or certainly looking at their semen analyses prior to any kind of treatment. I think there's strong evidence now that supports this around cancers and poor quality sperm. We need further studies, of course, to understand why this is happening. And I personally think that's very fascinating. But also, it's really important that we give patient-centric, individualized, holistic care, and that's using allied professionals and a team approach. Another area that I'm very interested in is the psychology and the psychosexual issues that occur with a cancer diagnosis, together with body dysmorphia. And I think that younger patients sometimes who have been diagnosed with cancer can go on to have issues with their well-being, and they're so worried about that their body is going to let them down that they sometimes take testosterone or steroids to really beef up, and that can actually be quite detrimental to them in the long term. So it's really important that, again, we're talking a lot, and you'd be surprised how much men like to talk. I think sometimes people think that they don't want to talk about these things, but I find that if there's a good listening ear, they will certainly be happy to explain their fears and worries. So in summary,
optimizing the quality of care starts with reducing the morbidity of the first treatment.
it's really important that cancer patients are cared for not just at the first line of treatment, but afterwards.
The needs of the patient changes with time, and therefore you need to do regular assessments, asking them what they need, what they feel are the problems, and getting that care for them with time.
It's also really important that expert oncological care is advised in terms of that they are supported throughout their journey and given and educated prior to any treatment taking place, and supported post-cancer treatment in terms of what we described earlier.
So the best care involves a multidisciplinary approach, and this is such things as symptomatic care that can be provided by Jasmine Centre, physiotherapists, psychotherapists, dietitians, and fertility experts. Thank you.
Thank you.
Thank you very much, doctors. We do have the opportunity, we're going to try to keep on time this morning, but we do have opportunity for dialogue with the presenters. So if you do have any questions, you can just signal by raising your arm. The microphone is on its way.
Thank you so much for that presentation, especially since yesterday I was eavesdropping and I heard some ladies talking about their general health and their vagina, and I was like, I don't want to miss this session for sure. But it got me to thinking too about mental health, and then you touched quite a bit on it, because one of the gentlemen in the statement made the statement of staying sane. And then you now mentioned the idea of the multidisciplinary approach. Are counselors included from the very beginning when people are experiencing, rather than the latter part of care? Are they included at the onset?
The easy answer is yes. At HSA, the tumour board that we have every other week, a psychologist attends, so where we can identify if there are any patients that would benefit from early intervention. However, as I said, things change with time, and as the follow-up goes on, even if you've got somebody that didn't think they needed that help and intervention, it's only later on, after they've gone through the treatment, it might hit them that about these feelings come out, and so it's really important to just keep mindful that that you may need a referral later on as well.
And similarly for the men, I think I said in my slides before that only 7% of urologists thinks that there's a problem and will get other allied professionals involved, but at 3 months post-operatively, 3/4 of them are sold. So I think that, personally, I think it's really important that people are involved very early on, because you can build up the rapport before the problems occur.